Okay, back to the centre of the world, and we're up there on the edge today. I want to talk to you about a story it's an evolving story really, and today's presentation is really in three parts. It's a little introduction to us and who we are, the issues we face, which you will see as being pretty similar to the ones that you have, but in different doses and a different flavour. And what I want to talk about is what we're doing about those issues, about designing our own future. Just a few words about the New Zealand health system. Generally speaking, we're a good performer, on those Commonwealth Fund measures. We do okay. We spend about 8% of our GDP, pretty small GDP, I'd have to say, on health. We have a universal access approach. We've always had a demand for health services that's far outstripped our ability to supply, and we've dealt with that over a period of time through a prioritisation process that's really principle-based, on the basis of transparency, equity, need, and the ability to benefit. We've also got a couple of unique and quite interesting features to our health service. Our drug buying agency, Pharmac, quite controversial in some parts of the world, and our no-fault accident scheme, which I think you guys have got too, haven't you? In the Netherlands, I think. Maybe you've got Pharmac as well now. Yeah. I think you have. Well, this is South Auckland, where I hang out most of the time. These are our people. It's 500,000 people or so, 450,000 people. Very diverse group, largely Polynesian, Māori, large Asian contingent there, large immigrant groups, big refugee centre there as well. It's a very poor area, actually, to tell you the truth. There's poor housing, there's a lot of unemployment, there's quite a bit of undesirable activity, and all of the health problems that go along with that. Now, we've had quite a lot of advances in healthcare, around the world, and many of you will recognise this slide that depicts, the first revolution in healthcare, John Snow's wonderful work to map the incidence, the prevalence, and the prevalence of cholera, and relating it back to the Broad Street pump, and that was a wonderful thing. The public health revolution has, transformed healthcare largely, but I must say, in my own area, we still need more of our public health revolution around things like housing, but we can come to that. The second revolution, which is personal health services, and I'm talking about hip joint replacements, and I'm talking about fancy drugs and all that kind of stuff. We've got some wonderful interventions now that have also helped millions of people. In fact, the total hip joint replacement, I think, was the BMJ operation of the century for the 20th century, a fantastic thing. Interestingly enough, in my own district health board, we don't have a problem finding people who need total hip joint replacements. Actually, we've got other issues, and we'll come to those. And, the third, or well, not quite the third, the second and a half revolution in healthcare, I think, is the rise of the quality improvement movement. But this quote, I think, from Lucian Leap, in a foreword to a book, How do Hospitals Fly, I think was the name of the book by John Nance, talks a bit about, the sort of promise and the hope that the quality improvement movement brought us, and to some extent the failure of that movement to really deliver. And largely I think it's about the things that Maureen touched on a bit today. It's about values, beliefs and behaviours, and until we get into that kind of territory, we're going to be struggling a little bit. Now, these are the problems that we face in our district health board, and I think in New Zealand too. And those ones on the left are the perennials. And I think that all of us in this room, I suspect, will be making some significant inroads into those ones on the left. We will have programs, and we will have some success. Certainly, in my place, we have. The ones on the right, inequalities, inequity, the sustainability of provision, of services, the sustainability of a workforce, failures to prevent both acute and chronic disease, the rising demand, and a failure to maximise value are the big issues that we're really facing now. And so we've recontextualised those problems, the traditional problems that we've been dealing with over the past decade or so, into this sort of new set, which I think fits better for the challenges of the future. Now, how do you deal with that? How do you deal with those problems? Well, look around. That's the captain of the All Blacks, Richie McCaw, you know, in that nail-biter World Cup final last year when we beat France, you know, but we won, and we're the world champions, you know. And actually, but that didn't happen by accident, you know, that was not a fluke, you know. The All Blacks have been the top rugby team in the world for quite a long time. They lose the odd game, but, you know, they win most of them, you know. How did that happen, you know? Is there something there that we should be looking at? Clearly there is. They've got a plan, they've got a strategy, they've got goals, they've got measures, they've got a pipeline, they've got a whole lot of things that actually we could do with. We look around also, and we don't have to look very far in our country to see some of the great benefits of that the indigenous, a greater knowledge of our indigenous people's culture will bring us, you know. So, he tangata, he tangata, he tangata. What's the most important thing? It's people, it's people, it's people. You know, this has been their folklore forever. What else can we learn if we're going to tackle these problems for the future? This is the well-known Spanish sociologist, Manuel Castells. And Manuel Castells has described the context for 21st century healthcare. A context in which, you know, individuals, well, it's actually a context for 21st century life, I have to say, because he's a sociologist, you know, but that healthcare sits in that context. And it's a context in which, you know, individuals, teams, organisations, systems and nations will succeed when they rely on their citizens. He says grow great systems or institutions, have a supportive culture, love the right technology and manage knowledge as if it was money. So, you know, what we did is we took on board all of that, and about 5 or 6 years ago conversations started within our district health board about the future. You know, clearly, you know, when you look at the stats, you know, the targets that we're supposed to hit, we're a high-performing organisation. You know, the problem is that they're the wrong measures. You only have to, you know, open the door and look around the corner, or open the window and look out, or drive through the streets to recognise there's a huge unmet need. There's a deluge of need that's already starting to impact on us to the point where, you know, we just don't have any spare acute capacity anymore. That's one of the issues we talked about. What are we going to do about that? Where are we going to get our staff from if we were going to expand our hospital services? As it is, we plunder a lot of our staff from, you know, places like the Philippines and India, you know. 40% of New Zealand doctors are often usually trained from overseas. We do lose a few. So we've got some real issues there. We're a great believer in the triple aim, actually, and that's one of our organisational sort of goal. And, you know, but for us, you know, we've looked at the issue of population health. We heard a bit about that from Maureen today, but we have a slightly different spin on population health. It's much more than immunisation. It's much more than chronic disease management. It's actually about having a self-reliant community that is productive and can look after itself and can make a future for itself and for its families. There's actually no more money either, you know, so this is all getting quite tricky, isn't it? You know, it's quite hard. There's no more money. But we also understand the drivers of 21st century healthcare. So that was the conversation that we had. What are we going to do? You know, and we decided the best thing to do was to not second guess the solutions to tomorrow's problems, but actually start to invest in people. Our people, our staff and our community, in the hope that they will navigate their way through. We were following Manuel Castells. Now, in thinking about this, we talked to people, we looked at frameworks, we interviewed people. Muir Gray, who was mentioned this morning. We spoke with Joran, we talked a lot to the IHI and Maureen. We went to the Kulturum and spent some time in Jönköping County, you know, a really magnificently informative visit for us. And we put a group of really good people together to think about how we're going to use all of the information that we've got, look at the exemplars around the world, and how can we craft an answer or a solution that may help us deal with the problems that we actually face. And out of that came Ko Awatea. which is actually, this is a building, but the building we hope will become and is becoming a lightning rod for people and ideas and actions, and that those people, ideas and actions will spread beyond the lounge where the good coffee machine is and the teaching rooms and the innovation lab into our hospital, into the community and across the country. And that's certainly what we're about right now. And the way we're doing that is that we've made some formal partnerships, but partnerships around a purpose. And what we've decided to do, and I've nutshelled that purpose in a paragraph, and it's really about equipping and preparing our clinical staff and our community with the leadership, knowledge, skills, support, confidence and license to help us navigate through those difficult times ahead. And that's what we call creating capacity and capability. And to do that, we've formed some formal partnerships with undergraduate universities, first of all, 3 universities in Auckland, and we now have a large presence of multidisciplinary healthcare students and teachers on our campus, and teaching them together and teaching them separately, but also being exposed to our staff and our issues and our ideas, and we get exposed to their ideas. We've formally partnered with the IHI, who have been supporting us in the work that we're doing and helping us. Also with Muir Gray in Oxford and his Oxford Centre for Healthcare Transformation. And we've been greatly helped in our work to date by the New Zealand Health Quality and Safety Commission, who see great value in the work that we're doing. The way our approach, the work that we're actually doing, is centred around 2 principles of excellence and sustainability. And they are sort of wonderful words, but underneath those words sit programs, actually, or sit a range of work streams that are very hard-edged, with very clear goals and very clear measures of performance against those goals over time. And all of those programs, it's like a driver diagram, feed in to what we hope to achieve. And in parallel, supporting those programs, a number of different philosophies, The supportive culture, I think, is the agar in which all of this takes place. And that supportive culture, I think we know what it is when we see it. It's quite hard to sort of describe it. But it's actually about being respectful. It's actually about listening to others. It's actually about not second-guessing the problems. You know the thing. You know the kind of thing I'm talking about. But the things in parallel are really a one-system view, rather than the stroboscopic interventions of well-meaning people in different locations. Developing a clinical leadership program that's actually related to a purpose, performance, improvement and change, and specifically improving certain skills and knowledge of our staff and certainly the community. I just want to talk a little bit about the one system view. And this is a diagram, in fact, actually, that I've adapted from a paper that Muir wrote in 1986, Muir Gray wrote in 1986 in the British Medical Journal, and it was called 4-Box Healthcare. And I've sort of taken it and fiddled with it with his permission. And actually, it talks about the reality of life, that in New Zealand, small country, there are 700,000 hospital admissions or discharges every year. It's not a large number, actually, 700,000. It's not a huge number. There's 4.5 million people who live in New Zealand. But actually, there are 16 million community consultations, and that's not just with doctors and not just with nurses. I'm talking about chiropractors, podiatrists, optometrists, that kind of thing. So, what we see here is what we know. People live their lives in the community, and that's what Maureen was talking about today. And what I've done with Muir's 4-Box Healthcare, which is based around aliquots of self-care, whānau care or family care, generalist care and specialist care, I've put them on a stick mat and I've walked them around that continuum between hospital and home. And what we're moving towards is a system where, wherever that person happens to be, if they're at home, why should they not be able to have access to some kind of specialist care? It may be by advice, it could be through some kind of technology, it could be by supporting the other care members in the team. And the same in hospital, how important is self-care in a hospital? I'm an ICU specialist. The data on self-care, on early mobilisation and exercise in critically ill patients is overwhelmingly positive in the direction of good outcome and reduced length of stay. So, this is the one system view that is sort of underpinning much of the work that we're doing. And when we come to the idea of clinical leadership, how does that support what we're trying to do? I've said related to purpose, its performance, It's about improvement. It's about change. And, you know, the questions, these are the leadership questions that we're posing ourselves and to everyone in our organisations. Do you know how you contribute to the performance of your organisational health system? And I think that's a really important question, and people should know, and their contribution should be valued. And if you haven't got a straight line contribution to a government target or an organisational priority, dollars to donuts, if you were to fall over in what you did, it would throw a burden on another part of the organisation, and your ability to hit those targets or do what you hope to do would lessen. Do you know how good you are? Do you know where you stand relative to the best? Do you know where the variation exists, and are you getting better over time? These are the leadership questions that we're asking ourselves. We're talking about, now I just want to come on to this business about building capability, you know, and our view of population health and self-reliance and productivity, you know, and creating that kind of pipeline from, you know, from the home into a productive job. We'd like to think it was in healthcare with us. But, you know, so we have a range of different activities that are going on at school level that our district health board are engaged in, some at primary school, some at secondary school, some at tertiary education, and certainly through the workforce development programs that we have to nurture and mentor and encourage and support our children to successful, productive lives. So they can start their own business. They can staff their own hospital if they choose to do it, or they staff their own health system. So we're investing quite a bit of work in that. And for our staff, you know, we're starting to think about a new way of working, trying to think of ourselves as an internal and possibly, and actually, an external consultancy. You know, it's actually about the right people. Have you got the right people? Are they willing? You know, are they prepared to learn? What are the skills that they actually need? How can you network those skills around the things that you need to do? And helping us with that skill development has been the work that underpins the sustainability and excellence programs. And we're putting quite a lot of our staff and other staff in New Zealand, with the help of the help of the Quality Commission, through a number of these IHI courses. So 9 months on, what are the lessons for us? Listen and engage, persevere. You know, you heard about Manukau this morning. It was 10 years. You know, this is a long journey. So perseverance is a pretty big deal here, I think. Clarity of purpose, strong leadership that cascades through the organisation and builds performance from the bottom up. If you want people to help you, you have to help them. You know, doctors are a miserable bunch, you know. They're sort of sad sacks, you know. They're not very happy, you know. Actually, we need to restore the joy of work. Work collaboratively and iteratively, and in the end, you know, we all love each other. But we're on a journey. It's an evolving story. If you were to come to New Zealand in September on the week of the 17th to the next Asia Pacific meeting, you might hear more about it and come and visit us. We'd love to host you. So thank you very much.
So time for discussion, questions, conversation. Hard to see with the lights here. David, why don't you, are there questions and comments?
Hi, I'm Ceri from, I work in the NHS in England. I'd just be interested to know if you've had any feedback from the people who you're trying to engender this attitude in, and you know what that feedback is like.
Yeah,
Could you repeat the question?
yes, the question is about feedback. Can you hear me without a microphone? Feedback from the
No.
people. Okay, sorry. The question is about feedback. What feedback have we had from the people that we're trying to engender these new ways of working? We've had a mixed range of feedback, as you would expect, actually. We've had some enthusiastic feedback, and we've had some less than enthusiastic feedback. And I think this is quite an interesting journey, and there's a very good lesson here for us. You know, we tried to be very careful about, you know, not dissing the past, you know, and the contributions that people are making. You know, the contributions that people are making now are really important contributions, you know. So what we don't want to do is actually give the impression that they're not. We want to support them in what they're doing, actually. And, you know, the contributions of everyone in the organisation contributes to the performance of the organisation as a whole. And how do we ensure that they've got what they need and the supports that they need to do that? So, you know, that is an issue, and it is an ongoing issue. And there are also issues around the pace of change. You know, there was an expectation that perhaps, you know, things would change overnight. And it's not that some things do change overnight, but actually this is a long journey. You know, we need to engage more and more people into that journey if it's going to be successful.
I had a question. You listed those very interesting questions for leaders.
Yes.
And I was wondering, how are those actually used? I mean, it's one thing to present them to a group, and in the minds of the directors, that's one thing, but are they actually used in some concrete, specific way?
Starting to be used. These are the questions that we're taking out to people to think about and to come back to us with how they see their responses to that. Clearly, I think when you come to the issue of how do you see your contribution within the organisation, that is an easier question for someone like me to help people figure out than to go to the renal service and say to them, you know, how do you know you're any good? Actually, they sort of do. You know, go to the mental health services. Actually, there's a range of national KPIs for the delivery of mental health services. But are they looking at those? Where are they compared to the best? Are they improving year in and year out? And how are they doing that? Some services are doing that now. Other services are struggling with some of the data. Other services are struggling with some of the concepts. So this is a, you know, moving piece.
So these are actually live working questions.
They
not,
are becoming
not just
increasingly
conceptual.
live working questions, yes.
Yes. Back there.
David, as a clinician, I have to respond to your comment that we are generally miserable.
I know you're not, John.
I want to point out to you that as a typical clinician, I am happy in my unhappiness. So the question is, and it always has been for me, it regards clinician engagement in these things. And if you've got any comments about how the clinicians have responded to these proposals, how have you engaged them at County Manukau?
The way we've engaged the clinicians is we've done a series of different engagement strategies. Some of them have been face-to-face, attending meetings, conversations. You know, there has been several months of ongoing consultations, and they continue, to tell you the truth. There are some people within the organisation who are way ahead in the way that they're operating. You know, they understand these principles because they're already, you know, working with them and doing them. Other parts of the organisation, you know, are under quite a lot of pressure. You know, the daily work, the urgency of the moment is really difficult. And you know, when you can't get your head out of the sand and look up, it's really hard for people to engage with this kind of work. Our job is to try and make their job easier, and to help them and understand what their problems are.
Yes, in the back.
Buy into the equipment, the work necessary to build capacity. Like, how do you get? And the other problem we have is that the staff gets the idea of, oh, this is the change of the week. So what happens on, you know, like the clinical staff end of the person who's not a physician and sort of is the recipient of, you know, doesn't really have that much say in what happens.
I think from the...
I'm sorry, could you kind of summarize the question?
Okay, you're asking about how to get buy-in from your senior leaders, you know, okay. And I'll just answer that one first, okay. This was a conversation that we had a number of years ago in the face of the pressures that we were under then and what we saw coming in the future. This was driven, you know, by a senior group of people within our organisation. And this is a long-term commitment by the board of our organisation and the senior leaders of our organisation to take this path, specifically around capacity and capability building. And actually trusting people within, the parameters that exist. We all exist within parameters. We've got, regulations, there's laws, there's professional values, there's certain targets that we need to hit. But how do you actually work within the constraints that you actually have? And who can make the best mileage within that territory? I think that we're starting to understand that the people delivering those services and the patients and their families are the ones who are going to inform that process the best and get the best results. And so there is a real commitment to that. That is a journey. This is not going to be straightforward, and there's going to be a lot of ongoing elbow grease that's going to be required here. Yeah, I think that most people do understand the value they add. The question is, do they feel valued? And I think that in many cases not. And so really it's a question, when people can see the contributions that they actually make, particularly around those leadership questions, if in my intensive care unit, for example, we have a quality board, we have some follow-up with patients, we have a range of different measures that we look towards that sort of reinforce whether we're heading in the right direction or not, or where our issues actually are. And we take those really seriously, actually, and they belong to us. And people, when they're in control of some of the determinants of your success, tend to feel much happier working in that environment. And actually, that's how performance cascades up. It cascades up from what goes on in my intensive care unit, up into the broader division that we're in, into the organisation. So people can see their place.
Last question.
Yeah, you're in front of.
Yes, sure.
Can I just add to the point that you've just made? There was a recent article published from a region in England which basically showed that junior doctors, they were asked a series of questions about did they feel valued by their organisation, did they feel valued by their managers, by the chief executive, by their consultants. And there was a significant number who said on all of those they did not feel valued. And I think what you said is quite right, which is that you feel, you understand the value of the work that you do, but you yourself do not feel valued. There's no acknowledgement or recognition of the work that you've done. And so there's no extra drive to maybe go the extra mile. You just keep doing what you've always done because, well, that's what makes you happy. If there was more, you might get more.
Thank you.
Right. Okay, I think we'll need to move on to the next presentation. We're going to hear next from Annemarie van Rhijn, who is a trainer for patient safety for the Netherlands and an investigator for healthcare errors in the Isala clinics. And her partner in this presentation is Gerda de Groot. That's the extent of my Dutch. And her position is as a complaints officer. And they're going to be talking about when healthcare hurts.
Yes, thank you. Welcome everybody to our presentation When Healthcare Hurts. After this session you understand the key aspects for patients, family and medical workers following healthcare errors. My name is Annemarie. My job is to guide the medical worker after a healthcare error and to do the investigation after a healthcare error. I also give trainings about patient safety for medical workers in our country. And I will tell you more about the key aspects how to guide the medical worker. My colleague, Gerda, is a complaint officer. She will tell you more about the guide, how to guide patients following healthcare error. And after this session, there is time for questions. We both work in Isala clinics in the Netherlands. We are the biggest not academic hospital in our country. Our values are open, professional, with heart and soul. And that means that we, in our hospital, that we give all the medical workers an introduction day for a day for all the medical workers and the doctors to tell them what we as hospital expected from them in related to our values. For example, we expect that every incident or near misses will be reported to our system or the real healthcare errors to our CEO. Another example is that we are open about our incidents to our patients. Also, we give training and tools for communication and how to manage healthcare errors for the medical workers. For this training, we use an actress. To play real situations together with the medical workers, so they can see and feel why good communication is important to the patient after a healthcare error. Experience shows that the medical worker, when things go wrong, better communicate with the patient and manage the situation after they had training. I would like to tell you the following story. In May 2011, the patient went for an open cholecystectomy. After surgery, the patient had a big pain, but that was normal. So the patient went home, and after 2 weeks, the patient came back to the hospital for a control by the surgeon. Again, the patient's wound hurts, and she was a little asthmatic. The surgeon did a physical examination and made an appointment for a thorax photo to check the lungs for an infection. The patient went for 5 thorax photos in 6 months, and none of the radiologists, different radiologists, saw the abdominal gauze. The abdominal gauze was visible by the lead wire, right below the thorax, but they were all focused on the lungs. After it was clear that they left an abdominal gauze during the open cholecystectomy in May 2011, the patient had an open laparotomy to cut the abdominal gauze in December 2011. Unfortunately, they also needed to get out some intestinal because it was infected. So what have we done? First of all, the surgeon informed the CEO about the healthcare error immediately after she knew about it. For the CEO, it's important to know the facts about the healthcare error and the condition of the patient. That's why we use a checklist for all the medical workers, so they know what to tell. On the basis of the facts, the CEO gives instruction to the investigation team to start a root cause analysis. But more important was that the surgeon was open to the patient about what happened from the beginning. Gerda will tell you more about that. Of course, it's important that we do a root cause analysis to find the causes after the healthcare error. This is even required by the inspection for healthcare in the Netherlands. But even more important is how to guide the medical worker. The medical worker is also a victim. That's why we have a procedure for how to guide them after the healthcare error. The risk of mental problems is present after a healthcare error. You have failed, and that's a normal feeling for every person who made a mistake. We know now that not only the person who did it is guilty, but also the system which we operate is also guilty. And don't forget, we work with patients and not in a factory, which makes it even more complex. In this case, the medical worker was a chief resident, and it happened just before she went to Australia for her training to be a liver surgeon. So she was afraid that the training no longer could continue. That's why we have a procedure for the medical worker to prevent that they get mental problems. First, there is a debriefing between the supervisor and the medical worker or a manager to tell her story, and after that we offer her a session with the social worker of the clinic. The reason that we do that is to guide the medical worker how to manage him or herself after a healthcare error, so they can handle their own feelings. Also, we are open to the medical worker about the findings after the root cause analysis. Experience shows that guiding a medical worker after a healthcare error ensures that they can function normally. Also, it's important to know that this process takes about 6 weeks. So there are 3 key aspects to managing healthcare errors. First, the promotion of your values, vision to the organization. And second, it's important to develop a trainings program for tools of communications. And last but not least, to have a procedure how to guide a medical worker after a healthcare error in your hospital. Gerda, will you tell us more about how to guide the patient and his family after the healthcare error?
Thank you. I'm Gerda, and I've worked in an intensive care unit as a nurse for 25 years. And now I am a complaint officer for 14 years and a mediator when things go wrong, when healthcare hurts. A case manager for the patient, the medical worker, the hospital, and sometimes the insurance of the hospital. Contact with a patient when healthcare hurts is most important. Apology, sincerity, and explanation about the situation are very important. At our hospital, it is usual and documented in a protocol that the complaint officer is involved after healthcare errors. It is relevant to involve this officer because she is not involved in the immediate care. She has an independent function at the hospital when it comes to complaints or healthcare errors. She can fulfill an important mediation role during the conversations with the patient, its family, and involved medical workers. She remains to the point of contact for the patient's questions about treatment, material and non-material damage. From experience, we now know that the patients appreciated immensely that sincerity and guidance is present at the hospital. All medical workers at our hospital are trained by the section Quality, which Annemarie and I are members of. They receive a helping hand about the do's and don'ts in situations like this. The complaint officer. The legal position of consumers in care has improved immensely in the Netherlands in the last few years. The WGBO, which in the Netherlands stands for Law of Agreement in Medical Treatment, made an entry in 1995. this law offers a large number of warrants of rights for the patient as well as the worker in the relation. Also, the patient has a right for this complaint to be treated correctly. Most institutes in healthcare have an open ear for complaints and communication about healthcare errors for a longer period of time. Complaint officers have become more and more an integral part of healthcare within institutes. The complaint officers have their own professional association in the Netherlands, which cares for contacts, education and trainings. I am a part of a national board. We often are asked to give lectures for institutes and employees in healthcare throughout the country. We are proud to say that our association is even approached for giving advice in creating a new law for clients' care. How treatment of complaints and guidance of patients after errors can be documented in a law. Contact with the patient has gone well. It concerned a 68-year-old woman. Of course, she was very sad after she heard a gauze has remained in her stomach, after she had the operation on her gallbladder. But she was very relieved that the gauze was the problem of her pain, and not a serious underlying suffering. The involved young doctor was still active in the hospital. In consultation with the patient, she operated the patient herself for the second time, though in presence of a supervisor. The nurses of the operating room personally stopped by to apologize. After surgery, I frequently visited the patient and had conversations with her husband and daughters, all discussed in true sincerity and complete harmony. I have also stayed in touch with the doctor, even by mail at a later stage, because this young doctor immigrated to Australia for 2 years. I informed her about the process. When the patient returned home, I visited her home to discuss everything and took with me, like in Holland, some flowers. We talked about the extent of damage and made closure in satisfaction, the material and non-material damage. If you ask the patient what was the most important to her, then the answer is that the doctor was involved and so honest, and that the hospital had a complaint officer whom she could always call if she had any questions. This gave them peace, which they badly needed in this special situation. It is important to guide the patient well when healthcare hurts. The patient is all right now. You can see she bought a new bike. And maybe she's on her bike now in Paris here. And I will stop with the words of Maureen of this morning. We're made to move, also if healthcare hurts. In what's the matter, then we ask now, what matters you? Thank you.
Thank you very much. Much food for thought.
Aha.
I have a question about sometime, if the risk or the hurt is accepted by the patient for several reasons, for example, cultural or religious beliefs. So we have a situation actually in the peripheral or rural areas in some places of Iraq, and by the way, I work with a couple of New Zealand nurses who really, I mean, capacity building oriented. So we have the traditional birth attendants. They do about 80% of the deliveries at home. And there is a lot of mistakes happening. These TBAs are not really part of the health system. We have the formal health system, and we have these parallel, TBAs that they do almost all of the, delivery at home. The problem is that when we approach them and we want to ask, or to update their knowledge, or to ask them for, attend some, recertification courses or something like that, they really, I mean, they say, okay, we are fine, and the patients or the women are really satisfied with us, and even if the risk happen, or even if the mother or the child, they got some kind of, different problems, even death, they will just accept it. It's a will of God or something like that, and they really play on that. They say, and they are strong cultural leaders. This TVA. So I mean, my question is, how do you approach that? I mean, you have the formal system, and you want to alienate, these, or you want to put them on board these TBAs. At the same time, they say, speaking of, that what's matter to the patient. The patient really, they want to deliver at home. If you ask them to come to the health facility, they will say, no, the privacy is important for us, and we want to give delivery at home. And then speaking about holistic approach, really we should respect this will of the patients, that they want. What's matter to them is that they stay at home, they deliver, and they accept the risk. So just in summary, how do you deal with this kind of situation where the patient accepts some kind of risk? I mean, is it more education or something like that? And then the other thing, how do you try to explain to these TBAs or health workers that really, I mean, it's a kind of ethics. It's not ethical what they do from our point of view. There is a gap between us and them, and really it's a problem to handle that. It is not now.
Yeah.
Yes, could you summarize the question?
It's very difficult for me to explain in English. English, it's not my language of my mother. It's the language from high school, but I shall try. Yes, that's an ethic problem, and it's also by us in Holland. But I always say, when I go to the patient and explain, and you do it with your heart, that's the most important, I think. And yes, it's another culture in Iraq than in Holland. And I think that's very difficult for you, and I must do it now with my ethic and my background from the Netherlands. But I think there's one thing the same at all over the world. When you do it with respect, and you do it by yourself, with your heart, I think that's the key to be there where you will come. But yes, maybe you can do something with this answer, but it's very difficult to talk for me about things are so different in your country. I have a Iraqi friend in Holland, and we discuss these things, but they are very different. But speak without your heart.
Building on what David Geffen said, it might be worth commenting on whether you think it would be useful for healthcare workers from Iraq to come to visit you and to see things working firsthand.
Yes, okay. You are welcome. Yeah. Okay.
Other questions or comments, discussion? Yes?
Maybe my comment would be, do you have a system of detecting the errors without waiting for the patient or the client to come back? And I think for us in the developing world, some of the errors that are common are misdiagnosis, like we saw. You keep taking the patient and they misdiagnose. and maybe we never ever get to know that because there's no system for checking the records or someone knowing that this was missed, and people never come back. So.
All right. Do we have a system to prevent before the healthcare errors?
No, to detect the errors.
Detect the errors.
Client comes back to us.
Yes, we have two systems. One system is after the healthcare error to do the investigation, and one system to prospective risico analysis. Is that the right word? Is to check the processes before it went wrong. But they will all make mistakes. Of every people will make mistakes. So the healthcare errors will exist through all. No, zeg je dat voor het hele jaar?
The whole year.
The whole year. Is that the answer for your question?
It sounded also as though the question were, is there a detection system for errors that have already happened but have not been reported? Something like the global trigger tool or something to detect very sensitive to errors.
No, we don't have such a system in our hospital. Maybe another hospital in our country or over the world? No. We are depending from the people who reported their mistakes in our system.
Are the patients counseled to be open about asking questions or making complaints?
Or the patients are
Are the
open?
patients, as they come for care, is it explained that they can ask questions or say they think there's a problem?
Yes, from the beginning. Yeah.
Yes, also the doctor, the worker in healthcare, when the patient is visiting the doctor, then the doctor have to say which can happen during an operation. Is that what you mean? Oh, okay.
Yes, back there.
I can't hear it. I can't hear it.
Obviously, I would expect your roles are expensive. Is there evidence to show that you're actually cost effective? Is there evidence to show that you actually reduce overall expenditure for your hospital in terms of, for example, litigation costs?
Can you
The question is, does your work reduce the overall cost of care, which then would help to pay to support you and your colleagues?
For example, with reduced litigation.
Yes, when you try that you prevent to go to that the patient is not going to court and tell them there what it costs. You try before in mediation to talk with a patient on material damage or
To prevent today.
yeah to prevent.
Do you have evidence to show that there is less complaints going to court
No.
before and after your role?
Yes.
Yeah.
Yes.
Okay.
And also, can I explain something? We work in a hospital, and we have 1,000 beds, and there are about in 1 year, I think, 30 questions about if it's wrong or is it right, or can you explain, and can we have a contact with the doctor about the NERI error or something like that. And I think when you goes in contact with the patient, you can't what is voorkomen? Prevent that the patient is going to court. And I think it was the last years, about 40, I think like that, and I think we cannot oplossen? We can reduce it, I think, within a half now.
Yes, two more questions. One there and then one there. Yes.
English is, for me, isn't my language, so I can explain my ideas. I often try to demonstrate the relationship between my work and the cost of litigation in my organization, but it's not easy. In my organization, we have the lower cost of litigation in my region, but I'm not sure that it could be connected to my work. And we have an incident reporting system similar as yours, but we have also other methods of checking errors in our organization. Some clinical audits are systematic clinical audits, and we can demonstrate the changes in time. We are adopting some indicators that we regularly check twice a year, and we can compare the data of an incident reporting system with other systems for checking safety in my organization. All of this is not enough to declare that I'm sure that my work is connected to the decrease on the cost of litigation.
Okay.
So have you seen now aspects or habits or attitude or activity in your organization to check errors and to compare the situation in time? Where are you from? I'm from Italy.
Italy.
And, from Udine.
It sounds like the question was whether you are able to compare the rate of complaints and the rate of lawsuits and so on in your area compared to other areas in the country.
Other areas in the country?
Yeah.
In our country? Yes. Yes, I think it's when there is a complaint officer in a hospital, there are less situations to court than before.
Right. Thank you. One more. Yes.
Thank you for your presentation. So I have one question. Unfortunately, not always the complaints comes from the patients. I'm talking about when the complaints comes from the labor unions. So I'm wondering if you have any particular strategy to work with labor unions in advance for the expected complaints. I mean, is there any particular strategy to work through the time with labor unions? I'm not talking about dealing with any particular complaints. I'm talking about preventing and working with them in advance.
The last thing I haven't understand.
I think the question is, do you work with labor unions, the unions of nurses, perhaps, or?
No, with patients. I mean,
Oh, with
in some cultures, in some countries, patients, healthcare systems are linked to any particular group of patients.
Group of patients, yes. Okay,
groups
yes,
of patients,
yes.
yeah.
Labor unions coming from
There's an open culture with that organizations in Holland. Yes, also.
So is there any particular strategy that you apply to work with them in advance of how to manage, I mean, I don't know, PR, lobbying, or any particular meetings in advance?
The patients organizations in Holland, they know that there is a complaint officer in the hospital to help the patients to look after yes, the contact. But that's an open culture, an open situation. Is that what you mean?
Yeah, no, yeah, I mean, that's the thing to manage that, but I'm wondering if maybe you have a particular strategy to work with them previously, I don't know, to show how the hospital works, how the particular procedures are you taking into account,
Yeah,
with them, and it's something in particular.
Have a strategy? Yeah, yeah. Okay.
Do you meet with patient organizations or labor unions to explain your work?
Yes,
and,
yes,
yes.
we do that in Holland.
Well, we've heard two kinds of capacity building that I think ordinarily might not be thought of as capacity building. One is to how to build the capacity to manage healthcare in the broad sense in the face of extreme limitations on resources, and the other is the ability to manage error, the capacity to manage error. So we're now going to hear the third presentation from Ceri Charles, who is the Deputy Program Director for the Hospital Change Program at Nottingham University Hospital.
Okay, I work for Nottingham University Hospitals, and I'd like to share with you a project that we've been working on for the last 18 months, and it's specifically around cleaning staff, so hospital-based cleaning staff. I think that you might have completely different systems for cleaning staff. I mean, I'm sure we can all agree that cleaning is fundamentally important in any healthcare sector. But I think the importance of, or the benefit of this approach is that it can be transferred to other staff groups. It can be transferred to other services as well. So the key messages that I'd like you to take from the session is about how we approach change management, how we sort of set up a project from a completely blank piece of paper in fairly challenging circumstances, and how we had to think very differently about how we approach this group of staff, and looking at the traditional ways that we usually employ that we couldn't use. And to get a group of staff to think very differently about how they work as well. So it's not a question of just coming to work, doing a shift and going home. We wanted them to feel part of the larger organisation. And lastly, the power of involving staff as well, because we achieved some very tangible benefits from a staff morale perspective, from a financial perspective, that we certainly were not expecting when we sort of set out on the course. So I'm just going to sort of reference these. These are our hospitals in Nottingham. There's a city campus and there's a Queen's campus, and it's just to say that they're quite significant in size. Here are some of our vital statistics. We've got nearly 1,700 beds across both sites, 87 wards, and we employ around over 13,000 staff across both hospitals, and about sort of 700 of those are cleaning staff. So probably about 650 direct cleaning staff and about 50 in a sort of management role within cleaning. So the reason why we sort of set on the sort of the course of having a project around the cleaning staff was that I work for specifically a whole hospital change programme that we launched across the hospital 2 years ago called Better For You. So we currently have 260 projects running across the hospital that are underpinned by a methodology and tools that we use across each one, and it can range from a very sort of intensive support project as sort of productive cleaning was initially, through to very light touch areas, and it's from clinical pathways through to looking at sort of how do we provide training for 13,000 staff across the hospital, so in many different areas, clinical and non-clinical. And to launch the project, we held, as it came to be known, events in the tents. So we put 2 sort of big marquees up on each campus, and for over a month period, all the directors in the hospital hosted sessions from about 5 o'clock in the morning till 12 o'clock at night to catch all the sort of staff groups. And as part of that, we spent a lot of time talking to sort of cleaning staff and other different groups of staff that we wouldn't normally see in the course of coming in between 9 and 5, as many of us do. And what the feedback we had from cleaners specifically was that they had no idea what was happening in the organisation. They had no access to emails, so they didn't know what the sort of vision for the hospital was, where it wanted to go in the next sort of 2 or 3 years. They felt very disenfranchised, and they felt that they played a very important role in managing sort of infection control and sort of reducing hospital-acquired infections, but they didn't seem to get any recognition for that. So that's why it was one of the projects we were really keen to sort of set up. And I think the importance of this is the fact as well, because a lot of the directors were involved in it from the chief executive level, we had instant buy-in, so that was one of the advantages, because they were at the sessions where the cleaning staff, and believe me, they didn't hold any punches when they were talking to people about sort of what things were not going well in the hospital. So right from the start, we had buy-in at a very senior executive level about wanting to support this project. And the difficulty or the challenges for us as a project team, there's only sort of 4 of us involved in the project, was that we were trying to engage people. So we said, right, we're going to start this project around cleaning, and we were trying to engage people when we had no concept of what it would feel like, what it would involve, and what benefits we'd get from it. And, there's a phrase about sort of trying to fly a plane while you're building it at the same time, and that's very much what it felt like. We were sort of out there sort of saying, there's a project. And one of the things that we did first is to see whether there was anybody doing something similar around cleaning, sort of either regionally or nationally, and we couldn't sort of detect any sort of activity specifically around this. So we looked at, what other sort of projects that could be sort of transferable, and one of these was in England we have a body called the NHS Institute for Improvement and Innovation. And they'd already tested something called the productive ward. So they'd launched a project several years earlier, which had been tested quite extensively across hospitals in Britain. And the key elements of the productive ward was that it was very much owned by the staff who worked on the wards and led by them. And there were specific models that they went through, so they could have a module on ward rounds, for example, and then the next module, so all the staff were expected to go through it. So we contacted the Institute and asked for their documentation, talked to them about how they set it up and approached it. And then we stole with pride. We took all of their sort of documents, and we looked at them to see, whether they were adaptable to productive cleaning and what we were trying to achieve. And I think the most important thing we did was to appoint 2 cleaners to the role of project leads. And I think it's really interesting to understand sort of people's motivations for wanting to get involved in change. And we had 2 very different examples where Wayne Kitchener, one of the cleaners, was very, very frustrated on a sort of daily basis from going in, seeing how things, could be improved, but not feeling empowered to sort of make that change. So that's why he sort of wanted to get involved in the project. And Sue Stevenson, who was the other cleaner who became a project lead, unfortunately her father had cancer, contracted MRSA whilst in the hospital up, in the north of England. And she said that in the final weeks, as a cleaner, she sort of sat in his room and sort of counted the amount of people coming in and out who weren't sticking to sort of accepted infection control practices. So, and it made her think, is this like this in my hospital? Are people doing this where I work? And that was her motivation to get involved. And I think it was a key appointment because a lot of the cleaners don't trust higher management. If they see me walking in, I've got no authenticity, no credibility. I don't know what it's like for them on a daily basis. And Wayne and Sue were really key in being able to sort of translate my sort of management-y speak into what their colleagues could understand and interpret. And there's a level of trust between them and their cleaning staff that didn't exist between sort of at the start between myself and the other members of the project team. So we had really specific issues and challenges, and one of the main ones is around the fact that this group of staff, there's, as I said, nearly 700 of them, didn't have access to any emails. So in any other project, you would sort of send out communication via that route. For us, it meant having to attend face-to-face meetings, and there are 25 different shift patterns in any 24-hour period across the hospital. So this is probably the most intense part of the project for us, was making sure that we give everybody the opportunity to either learn about the project or get involved in the project if they wanted to. And we took the staff feedback, and it fell quite naturally into sort of 3 or 4 themes. And those themes were around equipment, around processes, and around sort of people things. And then what we did was translate those themes into the project actions. And because, again, the difficulty is that these member staffs are not in a sort of controlled area like a ward. They come in, they clock in, and that's it. They all disappear to different parts of the hospital. So what we did was that we used their own staff rooms. There's a sort of staff room on each site, and that's where they usually sort of go for their breaks, which we turned into the project hubs. So each sort of campus had an area where we sort of said, this is what you've told us. This is what sort of actions we're taking. This is what we're going to do next week with them. So there was a continuous feedback, and because many of the staff didn't have English as a first language or had literacy difficulties as well, we made sure that it was quite interactive. So it was sort of pictures. We had face-to-face meetings with them. So lots of different medias of being able to sort of talk to people. And so these are the challenges. A group of staff, nearly 700, who have never, ever been asked in all of their sort of career, what does your job feel like? How does it feel working here? Could you do things in a better way? We had, in the cleaning services itself, a very hierarchical, paternalistic management structure where they met basically for 15 minutes with all of their staff once a month. And when I attended these sessions, it was very one way. It was them sort of saying, there's sort of 5 messages that we want to sort of share with you this month, and here they are. And it was like a machine gun of usually negativity. Don't do this, don't sort of smoke. If you're going to smoke, do that, put your coat on, and things like that. That it wasn't two-way at all. Again, distrust of higher management. They see us coming with a hidden agenda straight away, and that's probably because of previous experience of dealing with management. Staff scattered across the organisation, and as I said, poor vehicles of communication. So what we did was we translated all of this feedback, and this probably, as I said, was the most intensive part of the project. It took about 3 or 4 months to really sort of get into this. And we translated the feedback that they gave us into these project aims, and we wanted to release time to clean. We wanted to give them the opportunity to come to work and do the work that they were paid to do and wanted to do, rather than have interruptions from sort of different areas. And one of the key things that we got from the feedback sessions, which is again very, very powerful, was that they were telling us things that we could change within a week, things that had been happening for years and years. And one of these, for example, was around swipe card access, where most cleaners worked on one ward area, but could quite often be sort of moved to other areas to support them, but they only were given swipe card access to their ward. So if they were moved quite regularly to other areas, they'd have to sort of stand there, buzz in, wait for a nurse, which can take sort of several minutes, as I know sometimes, for somebody to respond, and then get onto the ward, and they might need a piece of equipment from a store cupboard off the ward and have to swipe back out again and go through the process on a daily basis. So much waste happening. And from that, and we changed that within a week. We talked to the people in charge of security and we said, we have physiotherapists, we have other people who have blanket access apart from high-risk areas. Why can't it be the same for cleaning staff? And that was changed within a week. And it was things like that, and putting computers in their staff rooms as well, so that giving them computer access so they could find out what was happening around the hospitals. Those were quick win things which really sort of they could really directly feedback from relate to the feedback that they had given us to actions that could help them on a daily basis in what they were doing. So here are some of the project tools that we did. basically we followed the same process as productive ward, in the fact that we had weekly meetings for about sort of 5 or 6 weeks with the cleaning staff and the nursing staff. And we tried to get medical staff involved. But that was quite difficult. So we sort of talked to them through the heads of service and the other sort of medical channels, if we needed their sort of support within the projects. So 5 to 6 weeks meetings of 1 hour meetings with a set of those staff. And at each one there was a specific issue to address. And here are some of the tools that we have borrowed, and here are some of the tools that we've created. So the first is around information. At the first session, we got the staff together and said, sort of, as a cleaning, as a sort of cleaner, what do you want people to think when you come to the ward? How do you want them to feel? And they started sort of talking about things like odour-free, safe environment, clean environment. And we put a board up. We had an agreed area where we could put a board up, very visible on the sort of ward area. And as you see, it says this is a clean ward, and it's it hits patients and visitors to that area straight away as soon as they walk in the area. We've also got, I know it's not a very clear slide, but we've also got the vision that the nursing staff and the cleaning staff created, a document there about roles and responsibilities, who should be cleaning what when. And also, and quite controversially at the time, was to get them to put the organisational cleaning scores for that area. And people weren't happy about that initially. But as they got into the sort of the movement of the project, and they were more happy to sort of be more open. So the ward cleaning scores are there also. We also have work schedules. We looked at how they worked. This was a 14-page document originally that sort of showed what needed to be done on a daily basis. So if you couldn't complete your tasks, you'd give your 14 pages to the next shift, and they would hunt through it to see what hadn't been sort of done, and sort of do that. Now it's a two-part, it's colour coordinated, and it's a 2-page document that they can see quite clearly what needs to be handed over. Again, looking at tools, they had trolleys that were quite small, quite unwieldy, and they couldn't put all their stock on, so they were forever going on and off the wards, trying to replenish things from the store cupboards. So the one investment we did do was to buy new trolleys that could fit everything on at one point. And we also colour coordinated the ward as well, and put that on the trolley so that when a new member of staff could look and see straight away what equipment they needed to cover the ward for one shift. And relationships, we sat down, we developed this ourselves, something called prime time cleaning. We sat down with the nursing staff and the cleaning staff and said, basically, how does this ward work? What are the routines on this ward? And we built up the work around that. So if cleaning staff are saying, we come here at 7 o'clock in the morning, but we can't actually get to the cleaning areas till 10 because patients are having been bathed and washed and having their breakfast. And we said, well, why don't you start at 10 o'clock then? And gave them the power to sort of change that. And that was quite, again, a sort of, quite a revolutionary sort of step for them to be able to sort of have control of their own work. Doctors, they said that they couldn't sometimes get into bays because doctors were having ward rounds. So they trialled having notices on the sort of ward round trolley saying, look, if it's okay and you can do it, can you start in that bay so I can really get on with my cleaning work in this area? Now that's had sort of quite a mixed reaction. It works well in some places, but we do sort of make sure that's where the feedback comes to the head of service, where we sort of say, you really need to sort of make sure that you're junior doctors and doctors understand that. But it works well in the main. So here's the results that we've had so far. We've trialled it in sort of, the sort of modules we trialled in 5 areas. We've had, we sort of specifically tested on 2 areas. And as you can see, we've got a busy neurology ward with 28 beds where patients sort of stay, much longer. And initially, pre-trial, they had 388 cleaning hours a month put into that area. And after the trial, that was reduced to 268. And the same for a respiratory ward, quite a busy ward, a real high turnover of patients in this area. and they save 52 hours a month. So it is, the important lesson was we can't put a blanket across all of them saying each ward is going to do it. It's going to be very individual and based on how many side rooms, what the layout of the area is. But we've done that. We've reduced those hours, 172 hours a month, by increasing as well our cleaning scores. So that increased. And we also we documented that we could spend more time on direct cleaning, so mopping and dusting and things like that, rather than sort of moving around and trying to sort of replenish stock. So these were the sort of results that we've had from the project. We've tested it in 12 other areas across the hospital with similar results, and they're sort of big areas as well, and not sort of distinct wards. And we're currently rolling this out across the organisation at the moment. So from June to September this year. And again, it's been owned now by the cleaning service operational team. So we've moved back as a project and sort of, embedded it into the service themselves. So they're confident to take this forward. The trolleys, from an investment perspective, the trolleys cost £216,000 to have, a trolley on each of the wards. So that's 87 wards and all the non-clinical areas as well. And we're on target to achieve £877,000 worth of savings for this year from the project. But also there are further benefits, so it's sort of spin-offs from this. The nursing staff have said, from the project that they would like to directly manage the staff themselves. So there's sort of, other benefits to be sort of reaped. We're exploring that with them at the moment. So I'll just sort of flick through this because of time, but we were sort of one of the finalists for the Health Service Journal, and we again invited cleaning staff around and asked them to nominate, who wanted to come down for the award ceremony. And these are some of the comments from the staff who've been involved in, the cleaning staff been involved in the project. And it's about more improved communication. They feel more part of the ward team now than they did previously. And again, this has been a sort of theme from the other sort of presentations this morning. Support from senior trust leadership. We've got Helen Bevan there, who's one of those. She's on the board for this conference from the Strategic Advisory Board, and she's from the NHS Institute. We've also got the Director of Operations and Medical Directors, and they used to sort of just drop into the hubs, talk to cleaning staff. So again, it's a sort of a chance for the cleaning staff to see that that they are appreciated, and that people are taking note of this project and the work that they are doing. So lessons learned, crucial role and support of the senior leaders in all of this and moving things forward. The productive cleaning has now been introduced into the junior doctor handbook for each new doctor that starts in the organisation, and that was why the medical director asked for that to be done. The importance of communication, keeping it sort of consistent and authentic, I think, is sort of key here. And not underestimating the benefits of staff engagement. And again, right to left project planning. When we started this, it's sort of, I think this is one of the weaknesses. It sort of meandered for the last sort of 6 months almost, because we didn't have an end point, because we felt like we were testing it. Whereas I think that if we'd had an end point that we wanted to achieve the project by, we could have worked towards that and been a lot more sort of focused. And again, letting people fly. One of the project managers is now left cleaning, but is now working on another project across the hospital, and he's doing sort of extremely well from that. So, so I think that's a really positive story to end on. But thank you very much. If you want to hear any more information about the projects, do email me or call me. But thank you very much.